Evening. Welcome to Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist helping people become heart attack proof. Since the pandemic 6 years ago, I've been doing these Instagram lives every Monday, 6 p.m. Central Time, answering your questions about cardiovascular disease, mitochondrial health, and longevity health optimization topics. Every Monday morning in my stories, you can submit your questions to be answered. If you join live and drop a question in the comments, I'll try to answer it for you if I can. If you're learning from this, outstanding, share with a friend. This is the best way for me to reach more people to understand that becoming heart attack proof is mostly within your own hands. It's not about, getting a prescription, even though those work at times, but it's much more about how you optimize your sleep, your stress management, your exercise, and somewhat your nutrition, but got to get your circadian biology right first before the nutrition really works optimally for you. So we'll answer the questions in just a moment. If people are interested in learning more about myself, you can go to my website, drtwyman.com. If you're interested in working with me and my team at Apollo Cardiology, we have an application on my website. We're currently bulking out about 3 months into the future. So if you want to work with us and get all the head to toe vascular screening, tip of the spear type of testing, AI-enabled testing, apply online and my team will reach out to you and make sure that we can meet your needs. So with that being said, we'll jump into the questions tonight. So the first question tonight is the carnivore diet detrimental if known to have elevated LPA? Not necessarily. They're two separate things. Lipoprotein A, everybody has it, but only 20% of the population has high serum levels of LPA. LPA can increase the risk of coronary atherosclerosis, can increase the risk of aortic valve stenosis. It's the number one genetically inherited lipoprotein that increases the risk of vascular disease. And it's something that if you have a lot of inflammation, tends to worsen. So if you have high interleukin-6, high LPA2 activity, high oxidized phospholipid ApoB, then LPA is more likely to be damaging your arteries. Now, carnivore diets, I've had many patients who have tried them. I always ask them, what is the goal with it? Is it an elimination diet, or is this something that you're trying to do for the rest of your life? Some people it works well for. Other people, are more sensitive to the saturated fats, and they may affect their lipoproteins, mainly by affecting their LDL receptors. So in some instances, a carnivore diet cools down the inflammation, net positive. In other instances, it raises the LDL particles, possibly net negative. The lipid guidelines just came out last week. I've reviewed them top line. It can take a little bit of time to dive into all of them. So follow me on my school community if you want to see my deep dive interpretation of what the new lipid guidelines really mean for you. But the carnivore diet might be beneficial, but it's a test, don't guess type of philosophy. Next question up tonight. This is a challenging one. I've seen this a few times. So somebody says that they had a CT angio with a calcium score of 0. So two separate tests. So the CT coronary calcium score test is a dry test, no contrast. So you only get the calcium score test. If they do a CT angio and they give you a calcium score test, that's looking at the hard calcified plaque. But with the CT angio, they should also be telling you, do you have any stenosis in the arteries? And if you use AI quantification, you can actually tell the type of plaque that's present as well. But let's just say you had a calcium score test that was, quote, normal, but then later had an invasive angiogram and showed a 60% left main lesion. Was this a miss or was this progression of the plaque? More likely than not, it's just the technology. Calcium score tests are not perfect tests. They do not see soft plaque. So I've definitely seen patients who have calcium scores of 0 and have severe coronary plaque that require coronary intervention. In about approximately 8% of the time, if you have a calcium score of 0, you still have soft plaque. In some instances, you have severe soft plaque. So symptoms, will trump whatever a calcium score test shows. So if you're having exercise chest pain, shortness of breath, exercise intolerance, or you end up getting a stress test that's abnormal, leading to an angiogram that shows a severe blockage, it's not a failure of the calcium score test. It's just that that test is not 100% sensitive and specific. It's a good screening test to try to restratify people into low risk or high risk. Do commercial spring water such as Evian or Core feature low deuterium? The short answer is no. Higher elevation waters, the glacial waters, will have slightly low deuterium. But if you're really looking for deuterium-depleted water for, health benefits because you have cancer or an autoimmune condition, you have to get the electrolysis type water. That's the only way to strip deuterium out of the water. You can't do it at home. So the spring waters, they may have slightly lower than tap water, and definitely lower than seawater, but they are not low deuterium products. Question, what is the best way to lower ApoB? It really will depend, but my short take would be, what type of plaque do you have? Are you a secondary prevention person where you've already had a heart attack or stroke? Or you're a primary prevention person where you've not had a prior cardiac event? If you're more towards the person who's at a higher event, you're going to generally want to look for an ApoB under 70. Many tools can get there. There's dietary interventions, particularly if you're eating a higher saturated diet. Some people will improve if they switch to kind of a more Mediterranean diet with monounsaturated fats and omega-3s. But oftentimes, lifestyle is not going to be the main thing that drives the lipoproteins. It's mainly genetic. So you can do a GB Insight panel to figure out what genes you carry that may raise your ApoB. You can do a Boston Heart Lab panel to look at are your cholesterol hyperproducer or hyperabsorber. The hyperproducers tend to respond better to statins and bempedoic acid. The hyperabsorbers tend to respond better to ezetimibe. And then pretty much everybody responds, very well to the PCSK9 inhibitors. But the downsides is that they're injections for the time being. The oral one will come out in a year or so, maybe sooner. And it's mostly just the cost differential. The PCSK9s are not covered by insurance, sometimes, reach a couple $100 a month. So there's 4 classes of medicines that have been proven to lower ApoB. There are some supplements that have some minor effect, but really depends on where you're starting and what your ApoB goals are. And it's always much more important what's going on with the arteries than it is what's in the blood. Is there a path from decades of sugar to heart disease? How is the process? What heart problem, I assume is what that says. So it actually starts more with high insulin. So insulin can damage the endothelial glycocalyx, which is the lining of the arteries. If the glycocalyx gets damaged, then it's more likely that lipoproteins will get retained in the artery walls and kick off a cascade where plaque will form. The high blood sugar generally trends later, and then somebody gets told that they have high blood sugar, now they're pre-diabetic, now they're diabetic. That process has been going on for many years, and it starts with high insulin. And carbohydrates play a role, but so does blue light by increasing cortisol, stress, increasing cortisol, poor sleep, don't recover well, don't optimize your mitochondrial function. So optimize your circadian biology, optimize your sleep, and then look at the nutrition. Can I talk about the benefits of taking Urolithin A? So this is a product from Twyman. This may help with mitophagy and may help with more mitochondrial being produced. Its actions, it works in the gut. Some people can break down some of the compounds that are in pomegranate. The gut microbiome will make it, and those people don't necessarily need that product, but the people who can't, the Twyman product makes it for them essentially. As far as I know, no known contraindications. The only downside honestly comes down from the cost of the product. As I often kind of joke with patients that there's 2 budgets for your supplements. There's the number of pills you're willing to take in a day, and there's the dollars you're willing to spend per month. Lots of interesting science behind it. Definitely has some benefits, probably for some exercise, endurance athletes. If you have a mitochondrial disorder, you probably would, rank this relatively high, but it's not something that I have every one of my patients consider. It's kind of case by case. And then the last pre-submitted question tonight, somebody says that they have a calcium score of 3,200. So to give people a perspective, a score over 400 is high risk. A score over 1,000 is very high risk. I've seen many patients with scores of 3,000. Highest score I've ever seen is well over 7,000. This individual says that they had a nuclear stress test that shows no blockage. What to do next? So a nuclear stress test does not indicate do you have no blockage. A nuclear stress test will tell you that you may not have a severe 70% blockage in any of your coronary arteries. But with a score that high, there's always a risk of what's known as balanced ischemia. You have so many coronary stenoses that the stress test looks normal. So if you have symptoms, that's going to trump a quote normal stress test. Also, the stress test does not tell you that you have no plaque that is blocking the arteries. You may not have 70% plaques, but unfortunately, half the time people have heart attacks, they have blockages less than 50%, and they'll pass a stress test. So it's more about treating the plaque than it is that the stress test is normal or abnormal. Stress test is abnormal and having symptoms. You're going to meet my colleagues in the cath lab, and they're going to talk to you about, do you have a severe blockage, and if you would benefit from a stent relieving that blockage. But in that instance, the stent makes the blockage look smaller, but the stent does not do anything that you want. It does not reduce your risk of having a heart attack, and it does not reduce your risk of dying from vascular disease, because it doesn't treat why you developed the plaque in the first place. So I usually break it down into three kind of categories. What's affecting your nitric oxide pathways? How much inflammation do you have? What are your lipoproteins? And pretty much in that order. I care much more about how well your body produces nitric oxide, and do you have unexplained inflammation, than I care about your lipoproteins. We're going to address them, but if you don't fix the nitric oxide pathways, you're not going to get what you want out of this. So testing, don't guessing. In my practice, we do head-to-toe vascular testing. We do vascular reactivity testing with endopads. We do max pulse testing, pulse wave velocity testing, central rate of blood pressure estimations. We're trying to see how stiff your arteries are. That gives us an idea if you have a nitric oxide issue. There's comprehensive blood work we usually do with Boston Heart Diagnostics that can tell us, how much oxidative stress or inflammation you have. Colloquially, think of it as how much inflammation is fire, oxidative stress is rusting. How much are your arteries on fire, or how quickly your arteries rusting? Then use whatever tools you can to figure out the lipoprotein situation. If you have access to genetic testing, GB Insight is the one I usually recommend people consider, and then get to work at fixing all the risk factors that you can. Most people, unfortunately, focus on high blood pressure, cholesterol, diabetes, smoking, obesity. Important, but there's nearly 300-400 different risk factors for vascular disease, and it often starts with things that are damaging the glycocalyx, depleting your nitric oxide, kicking off these oxidative stress and inflammatory cascades. So I think those were the pre-submitted questions. We'll check and see if there's anything in the comments for questions. First comment, does too low of cholesterol levels have any association with anxiety or depression? I would say possibly, but it really depends on what low cholesterol levels are being caused by. If it's naturally low cholesterol levels, because you have a loss of function PCSK9 enzyme, probably not. I have family members who have that gene and lived into their hundreds. If it's low because you have cancer, you have an autoimmune condition, a chronic infection, that is probably what's driving the anxiety or depression. Now, I think you're probably answering the question, is your cholesterol low because you're on pharmaceutical or nutraceutical intervention? A little bit different answer. I would say look at your desmosterol levels. If your desmosterol levels are low, then possibly you might have some issues with some side effects that are more brain associated, and you would just dial back on the lipid-lowering therapy and use a different agent for those individuals. But in of itself should not directly cause those concerns. All right, well, those were the questions for the evening, it looks like. So as always, Monday, 6 p.m. Central Time, we answer these questions. I love trying to help people become heart attack proof. That's my mission. Apollo Cardiology is the practice I launched back in 2019 to focus on that. I used to be an invasive cardiologist helping people at the end stage of vascular disease when they're having the heart attacks. It's very rewarding, but I thought it was a little bit more rewarding to prevent the heart attacks. So that's how I kind of roll now, trying to research the best tools to figure out what the person's risk of atherosclerosis causing them an event is. There's a lot of great, interesting things that the AI worlds are developing for us. I have some new gear coming down the pipeline that's going to help people with just an EKG, tell them if they have a weak heart. There's devices we have that can tell you, do you have issues with your valves? We can do things non-invasively that used to require us to take you to the cath lab to figure out. So if you're ever interested in that kind of evaluation, we do offer these 2-part deep dives where we do a head-to-toe screening, comprehensive genetics, lab work, and then the follow-up visits can either be done live with us or we can do them telemedicine. So if you're interested in those type of evaluations, I am booking out about 3 months in the future right now. My team at Apollo Cardiology can help you. You just go to drtwyman.com/apply. You can check that out. And then the other kind of call to action tonight is I do have a school community. It is called Becoming Heart Attack Proof. At least once a month, I'm doing a long form Ask Me Anything like this, but people can actually pop up. I can see them. If we can do a little bit more back and forth. And then this is where I'm dropping some of the things I'm learning. So if I listen to an interesting podcast, I give my take on it. Be attending conferences. I'm using actually the Plod device to record a lot of messages and meetings, and it does AI summaries, so I can kind of download a lot of the stuff I'm learning to the people who want to learn more along with me. So if you're interested in that, there's a free 7-day trial at school. So it's drtwyman.com/school. So hope you guys enjoy. Again, if you like this, give me some feedback, drop off your comments, and then I'll see you back next Monday, 6 p.m. Central Time.